Well, thanks so much for inviting me here today. So I'm going to be talking about temporal variation in psychosocial factors and physical activity levels amongst patients with heart failure. And this was work that emerged from my K23, although probably my most important disclosure is that I am a heart failure and transplant cardiologist. And so this work was really motivated by the challenges that I face in working with my patients to try and increase physical activity and exercise. So heart failure, as many of you know, is a chronic, highly prevalent condition and a leading cause of morbidity and mortality in the United States. And we know that physical activity is safe and effective for patients with heart failure, though few heart failure patients are physically active. And I always kind of give the example of one of my patients that I work with where we set goals around the number of times that he would unload his dishwasher. They are so inactive that really things that we think of in our life as routine represent physical activity for many of my patients. And there's the thought that psychosocial factors may influence physical activity levels, although this relationship is poorly understood. And so this observational study was designed to explore stable psychosocial factors and within day temporal changes in symptoms and situational psychosocial factors in heart failure patients and their potential association with physical activity levels. And the theoretical basis for this study was self-determination theory. And I know many in the audience are familiar with this, but this is an evidence-based approach for understanding and modifying human behavior and centers on the importance of values and goals and behavioral self-regulation and posits that competence, autonomy, and relatedness contribute to an individual's adaptive function. And we chose this given some emerging evidence within heart failure that self-determination theory and kind of related interventions can improve heart failure self-care. So we recruited adult patients with symptomatic heart failure. We provided participants with a smartwatch to objectively measure their physical activity levels. And then we asked participants to answer baseline and 4-week surveys and twice daily ecological momentary assessments for a month. And surveys were taken from the published literature and were focused really on those more stable psychological factors that we didn't anticipate would change over the study period. And then these EMAs were designed to assess factors that we hypothesized could be influenced by context. And the EMA was designed as 12 questions and intended to be answered in approximately 3 to 5 minutes. As I mentioned, we focused on self-determination theory, and this kind of overlying framework was this distinction between traits and states. So we thought of traits as being these stable psychological factors, things like autonomy, social support, outcome expectancies, and mood, and then these temporary or context-dependent states around heart failure symptoms, perceived competence for physical activity, vitality, positive and negative affect, and fear of physical activity. Between February and June of 2024, we enrolled 30 patients into the study. And participants were on average around 60 years of age. They were equally split between men and women largely. The majority were white. And these individuals had moderate heart failure symptoms when assessed by the Kansas City Cardiomyopathy Questionnaire and the New York Heart Association classification, which are standard assessments that we do amongst patients with heart failure. And we had a range of heart failure phenotypes represented. We had outstanding adherence to the study protocol, so participants wore their watches for a median of 27 days, and they wore their watches for about 21 hours each day. So overall, the physical activity that we captured was representative of their daily physical activity levels. And the median step count over the study period was 3,700 steps a day, which I think is probably actually slightly more active than the patients that I see in clinic, but is on par with what we see in other trials of heart failure patients. So participants overall had high baseline levels of identified and intrinsic motivation. So this may not be representative of all heart failure patients. They had relatively mild depression symptoms and fewer overall barriers to physical activity. And then we did a series of mixed effects models to explore the association between baseline survey scores and mean daily step count. And I think that this may not be as surprising to many of you in the audience, but we did find significant associations between motivational quality and physical activity levels. So for example, each 1-point change in identified regulation, a form of autonomous motivation, was associated with an 18% increase in daily step count. And we found significant associations as well as it relates to barriers to physical activity and physical outcome expectancies. I think what was more interesting, though, about this was related to the association in some of these time-varying constructs and the time scale over which we saw these change. So this is from our EMAs, and participants initiated 84% of the EMA prompts. And just taken overall, on average, our participants had overall moderate heart failure symptoms, high positive affect, moderate competence for physical activity, and moderate levels of vitality. And so we tried to quantify the variation in these constructs on both the order of a week and then over the month-long study period. And as you can see here, this is I'm showing you now for the month, EMA constructs varied significantly. So about 40% of participants had a 50% or greater change in heart failure symptoms. 60% of participants had a greater than 50% change in vitality. And we saw similar variation as it related to competence for physical activity. And just showing you this here graphically in another display, you can see this spider plot on top, and certainly you're not meant to kind of look at this, but hopefully you could just perceive that these are these crisscrossing lines and that there is significant variation in these constructs, again, over this very short period. And we conducted a series of mixed effects models, again, to explore the association between EMA constructs and physical activity at 4 and 12 hours. And so what I've shown you here are the results for 12 hours. And as you can see, we saw heart failure symptoms, competence for physical activity, vitality, and positive affect were all significantly associated with short-term physical activity measures. And so to put this into context, for example, a 1-point change in competence for physical activity on a 7-point scale was associated with a 14% increase in short-term physical activity. So obviously there are lots of limitations. This was a single academic center, predominantly white population, participants were English speaking. Our sample size was quite small, so we have limited overall power and also for specific subgroup comparisons. Some constructs may have been inadequately captured or represented through our EMA, and we only evaluated step count, but we know there are lots of forms of physical activity. And of course, causality cannot be determined given the observational design. So putting this all together, stable psychosocial factors like motivational quality were significantly associated with physical activity levels. But perhaps really interesting is that these temporary states, which may be context dependent, such as vitality, competence, and heart failure symptoms, all varied within and across days for a given individual, even over this really short study period. And these changes in psychosocial states were significantly associated with immediate physical activity over the next 4 and 12 hours. So we've really put this together and used this as evidence to support that multifaceted interventions are needed. So these findings support that future interventions to augment physical activity really may require a combination of strategies that target both longer-term changes in more stable psychological factors while also providing in-the-moment support for some of these more temporary context-dependent states. And so one effective approach that we're currently testing may consist of a more resource-intensive strategy at lower doses, so that could take the form of health coaching, counseling, cardiac rehabilitation, but then pairing that with a dynamically tailored dynamically tailored mHealth intervention, for example, a just-in-time adaptive intervention. And again, we're currently testing that both in heart failure patients, but also in a cardiac rehabilitation population. So I went through those really quickly. This was just published earlier this month in Circulation Heart Failure for those that are interested. And I know I'm a little over time here, but happy to take any questions.
Do we have any questions? Oh.
Yeah, I just had a question about one of your metrics. You noted physical activity barriers. I'm wondering how you measured what that was.
So it was a validated scale that we had that assessed different barriers to physical activity. So these could be kind of the environmental context barriers where somebody lives, their access to equipment, to shoes, things of that nature, all the way to kind of like, I don't want to, I don't have the time to wash my hair after. And so it kind of assessed a range of more environmentally focused factors.